Morning. I'm Dr. Achieve, Cairo University. I'm a professor in Cairo University. Now we're discussing the biomechanics of shoulder stability and the pathoanatomy of shoulder instability. To discuss shoulder instability, we must first discuss the factors affecting shoulder stability. These factors can be divided into static factors as well as dynamic factors. The static factors may be divided into bony factors, the labrum, ligamentocapsular structures such as the glenohumeral ligament and the rotator interval, other factors including negative interarticular pressure and adhesion cohesion. The dynamic factors may be divided into rotator cuff muscle action, the scapulothoracic muscle action such as the serratus, trapezius, levator, and rhomboids, as well as the biceps tendon. First, we'll discuss the bony factors. There is a very famous saying that says that the shoulder joint has no inherited bony stability. This is because of the fact that the articular surface of the head is 3 folds that of the articular surface of the glenoid. It is like a big basketball settled on a teacup. That's not all. It also rotates in 180 degrees in one direction and almost 160 degrees in the opposite direction. But this is not totally true. Why? People usually move forwards. While moving forward, we tend to fall forward on our outstretched hand. In this position, when we fall, the head moves posteriorly. So by logic, we should dislocate posteriorly in most of cases. This is not true. Why? Though we always fall forwards and the head is pushed backwards, the glenoid has, as part of the scapula, the whole scapula has moved and rotated forwards. The scapula is placed 5 centimeters from the midline between the second and seventh rib, upper rotated 10 to 15 degrees, and internally rotated 30 to 40 degrees. Thus, the whole scapula has moved to place the glenoid behind the head. So whenever we fall, the head tends to move posteriorly, but the glenoid is behind it, preventing it from posteriorly dislocating. The scapula is anterior tip 10 to 15 degrees, and the glenoid is retroverted 7 to 12 degrees. The humeral head has further retroverted 30 to 40 degrees to face the posteriorly placed glenoid. So we can say that the shoulder has an inherited bony stability for the common type of injury, which is falling forwards. The second static factor is the labrum. The labrum is formed of a fibrocartilage structure placed or attached to the edges of the glenoid. The labrum adds to the stability of the shoulder by first deepening the glenoid. When we remove, in cadaveric cases, when we remove the labrum, the glenoid loses 6 millimeters of its depth. Second thing, the labrum increases the glenoid surface. Thirdly, and most importantly, it gives attachment to the glenohumeral ligaments, which are the main static stabilizers of the shoulder. The ligamentocapsular structures, as we've said, can be divided into the glenohumeral ligament and the rotator interval. The glenohumeral ligaments are formed of the superior glenohumeral ligament, middle glenohumeral ligament, and the inferior glenohumeral complex. The superior glenohumeral ligament is tight at 0 degrees of internal rotation, and this prevents or limits the anterior and inferior translation. The middle glenohumeral ligament is tight at 45 degrees of abduction, limiting anterior translation in such a position. The most important one is the inferior glenoid ligament, and it acts by two mechanisms, as a check rein and by its buttress effect. A check rein is simply like a rope. It is. When tightened, it prevents further translation of the head, but it cannot prevent side motion of the head. To prevent side motion, the attachment of the glenohumeral ligament must be further lateral over the head. This would add a buttress effect to the glenohumeral ligament, thus preventing any anterior or posterior translation of the head. The inferior glenohumeral complex is formed of the axillary pouch, the anterior band, and the posterior band. The anterior band is tight in abduction and external rotation, the position in which the head tends to move forwards, thus preventing this anterior translation of the head, while the posterior band is tight when the arm is adducted and internally rotated, the position in which the head tends to move posteriorly. The posterior band is tight in such a position, preventing any posterior translation of the head. The rotator interval. The rotator interval is formed of three main structures: the superior capsule, the superior glenohumeral ligament, and the coracohumeral ligament. All these three structures add to the anterior stability of the shoulder, preventing any anterior translation of the head. Other static factors that add to the shoulder stability include the negative interarticular pressure and adhesion cohesion. Within the humeral head, with the glenohumeral joint, any air inside this watertight, airtight structure is sucked. This produces a negative interarticular pressure that sucks the head against the glenoid, thus adding to the stability of the shoulder. Adhesion cohesion. We can understand it if we imagine two small glass slides with a thin film of fluid in between. It is very difficult to remove them from each other. This is because of the adhesion cohesion effect between the two glass slides and the thin film of fluid in between. The same is present in the glenohumeral joint. The head and the glenoid, in between them, there is a very thin film of synovial fluid. This produces this adhesion cohesion effect. Then we will discuss the dynamic factors, the most important of which is the rotator cuff muscles. The rotator cuff muscles act by two mechanisms: compression of the glenohumeral joint and their coordinated action. The rotator cuff muscles do not act by an agonist-antagonist effect. They act by a coordinated action, and we'll see more details about this. The rotator cuff muscles are formed, as we all know, from the supraspinatus, infraspinatus, teres minor, subscapularis. It is formed of five layers. We don't have to go into the details of which, because this is needed in another session. But they function by three mechanisms: biomechanically, as head depressors and muscle spacer effect. They add to the nutrition of the shoulder joint by their motion. And the most important for this session is the stability. The stability is produced by the dynamic constraint effect of the rotator cuff. How can this be? When the subscapularis and the infraspinatus, as well as the supraspinatus, all contract, they push the head against the glenoid, thus compressing them both, preventing any anterior or posterior translation, allowing only rotation. This is a very important action, but even more importantly is the coordinated rotator cuff effect. How can this be? During abduction external rotation, the position in which anterior dislocation occurs, During this position, to perform an external rotation, the teres is contracting. It is the main external rotator of the glenohumeral joint. If the rotator cuff muscles were acting in an agonist-antagonist mechanism, then the subscapularis, which is the internal rotator, should be inhibited. This is not true. While external rotating the glenohumeral joint, the teres is contracting at the same time. The upper subscapularis is contracting, thus tightening the anterior band of the inferior glenohumeral joint, inferior glenohumeral complex, preventing any further anterior translation of the head. This is unique for the rotator cuff. All the joints around the body have muscles that act in an agonist-antagonist way, like the elbow. When the brachialis and the biceps contract to flex the elbow, the triceps muscle must relax to allow this flexion. But in the rotator cuff, the external rotator, which is the teres, is contracting at the same time with the upper subscapularis to tighten the anterior band of the glenohumeral joint of the glenohumeral complex to prevent any further translation of the head. So we can say that the coordinated motion or the muscle balance during the motion is the main function of the rotator cuff, and it is the junction between the static and the dynamic stabilizers of the glenohumeral joint. Pathoanatomy. Different pathologies occur to produce shoulder instability, the most popular of which is a labral tear, what's known as a Bankert lesion, or bony loss, whether at the glenoid side or the humeral head side, or capsular redundancy due to repeated microtrauma, such as in baseball pitchers or volleyball players or swimmers, especially dolphin and backstrokes, or due to capsular laxity. This is a constitutional problem, which is generalized laxity since birth. These patients present by different presentations. The most common, by the way, is asymptomatic. Many patients with generalized laxity have, during examination, excessive anterior translation or excessive posterior translation or positive sulcus sign, yet they are not symptomatizing. They are not symptomatizing, so do nothing to them. Another group present by pain, mimic impingement. This is due to the instability. When the head, especially those with capsular redundancy, as in volleyball pitchers, on pitchers in baseball or during volleyball prayer or the swimmers, they come with pain. The pain is simply because the head is always, the capsule is wide due to the repeated microtrauma, and the head is always translating excessively forwards, thus fraying the anterior labrum, causing some pain, as well as another fact that the rhomboids and levators, as well as the infraspinatus, are contracting suddenly to prevent any further translation of the head, pulling it backwards to prevent further translation of the head. This would lead to spasm in these muscles and pain. So many patients were suffering from instability come with an impingement. This is not impingement. This is not overcrowding of the subacromial space, but it is excessive translation of the head of the humerus. The most famous clinical presentation is dislocation. These dislocators have been divided by Rockwood, God bless his soul, he passed out a couple of weeks ago, into traumatic type and atraumatic type. The traumatic type, TUBS, it is always due to trauma, it is unidirectional, it is due to a Bankert lesion, and usually needs surgery. The atraumatic type is, there is no trauma, atraumatic, usually multidirectional, almost always bilateral, almost always treated by rehabilitation, And if needs surgery, it needs an inferior capsular shift, not a Bankert repair. Neer, Charles Neer added a third type, the acquired type. He stated that these patients have an excessive overhead activity, always in this position, like the dolphin swimmers or the backstroke swimmers or the baseball pitchers or the tennis players during serving. These overstretch the anterior capsule, leading to instability while the labrum is still intact. In general, we can divide shoulder instability according to the direction into unidirectional, bidirectional, or multidirectional. To discuss these three types, we can divide them into the traumatic, atraumatic, and acquired type. In the traumatic type, there is history of a major trauma. The labrum is torn, what's known as a Bankert lesion. The capsule is usually normal, except when there is excessive repeated shoulder dislocations, more than 6 or 7 times. The capsule becomes overstretched and redundant. The bone shows an impression fracture in the femoral head, but there may also be a glenoid defect. The X-rays shows this Hill-Sachs lesion. Clinically, there is history of a definite trauma. It is not self-reduced. It is severely painful, usually unidirectional or bidirectional and to inferior. The initial treatment is usually immobilization, except for young athletes. This is an exception in which most of us prefer to perform a Bankert repair very early on during the first dislocation. But all of us agree that if there is a recurrence of anteroinferior instability, a labral repair is needed, plus or minus a bony procedure if there's a bony defect as well. The atraumatic type, it is due to congenital laxity. The labrum is intact, it's not detached. The capsule is very wide and lax. The bone is normal, there is no X-ray changes. There is no history of trauma. It is usually self-reduced. Commonly, it's asymptomatic, and it is almost always multidirectional. It is treated by coordinated rotator cuff exercises to teach the rotator cuff how to perform. If surgery is needed, it is in the form of an inferior capsular shift. The acquired type, which was added by Neer, is due to a repeated microtrauma, due to an overhead activity in the abduction external rotation position, like in dolphin swimmers or backstrokes. The labrum is frayed due to this excessive overhead translation of the head, of the humeral head over the glenoid. The capsule is wide and redundant due to overstretching over the time. The bone is normal, the X-ray changes, there is no X-ray changes. They always give history of excessive overhead activity. The first dislocation is usually due to a mild trauma. It may be self-reduced. It is less painful than the traumatic type. It is bi or multi-directional. The initial treatment is the same as the congenital or atraumatic type, in which the treatment is coordinated rotator cuff exercises. Teach the rotator cuff to contract at the same time in a synchronized manner. If it is recurrent and rehabilitation does not give us the estimated or what we aim at, then capsular repair is needed. Surgical procedures to treat anterior and anto-inferior shoulder instability. This includes a labral repair. This was first described by Bankert in 1938, or a capsular repair in cases of capsular redundancy, or bone block procedures in cases where there is bone loss, or procedures involving the subscapularis or osteotomies. Labral repair. It was first described by Bankert in 1939, and now we perform it arthroscopically. There are different types of labral repairs. In 1906, Perthes described the first type of labral tear, which is a detached labrum with an intact periosteal sleeve. Then Bankert in 1939 described his type, in which there is a labor detachment with a severed or cut preosteus sleeve. In 1997, Navieser described the Alpasa type, in which the labrum is detached and reattached more medially over the glenoid neck, and fibrous tissue is formed to fill this defect. The Glad lesion was described in 1939, in which the labrum is detached with part of the articular surface of the glenoid. And another type, which we all see commonly now, is a bony pancreas, in which the labrum is detached with part of the anterior edge of the glenoid. Labor repair or pancreas repair. Arthroscopic pancreas repair was first described by transglenoid sutures, in which sutures are passed through the glenoid and tied over the fascia of the infraspinatus. Then staples were used, then tucks were used, and finally, now the most popular thing is the anchors. This is a short video to demonstrate the case of labor repair using anchors. First, we identify the tear. This is a tear extending from 3 o'clock till 6 o'clock inferiorly. We mobilize the labrum to allow later on proper repositioning of the labrum over the glenoid. Then we prepare the bed. We decorticate it to reach a fresh bleeding surface that will help healing later on. Then we place our anchor. This is an anchor placed at 5 o'clock. We retrieve one of the two suture material through the labrum. Then we start checking the mobility of the sutures. Then we tie our knot and push it downwards over the labrum. I prefer to place the knot over the banked side of the labrum to push it over the glenoid like a bumper. Now we tighten it using a suture pusher, not pusher. Then we cut our sutures. This is the second anchor. It is placed at 4 o'clock. We do the same procedure, tie our knot, push it on the labral side of our suture. I usually use a third anchor as well. Now, capsular repair. It was first described inferior capsular shift by Near and Foster in 1980, then Near developed it into near cruciate repair in 1985. Simply inferior capsular shift, there is an inverted L-shaped incision performed into the inferior capsule, and this triangular flap is later on shifted upwards, thus reducing the wide axillary pouch and reducing the size of the capsule. This was later developed into the knee cruciate repair, in which there is a T-shaped incision is performed and both triangular flaps are double-breasted. And then he stated that we should close the rotator interval. This is a short video showing arthroscopic inferior capsular shift. This is a case of recurrent shoulder dislocation with an intact labrum, a very wide capsule. We perform a trough along the humeral side of the capsular, of the anterior capsular attachment. This is a trough along the humeral side of it. Then we perform an inverted L-shaped incision. This is the vertical part of the incision. Then we perform a transverse incision to perform an inverted L-shaped incision in the anterior capsule. Then we pass our sutures at the apex of this triangular flap. This is a suture passer, sharp suture passer. Then we pull one of the two limbs of this suture material through the upper subscapularis using a sharp suture puller. Thus, the suture material is passed through the apex of the triangular flap and the upper subscap. Then we pull the second limb of the suture material. So we have now a loop passing through the apex of this triangular flap and over the upper subscapularis. Tightening this suture will pull or shift this triangular flap upwards, performing an inferior capsular shift. This is repeated at a more lateral position, just near the triangular trough, the already performed bony trough. It is the same procedure as the first suture. Now tightening this suture will pull this triangular flap and bring it in contact with the already previously performed bony trough. And this is how it looks at the end. The very wide capsule had been reduced in size. Bone block procedures. The French now are popularizing the most popular of which is the Etiology procedure, which was first described in the early 50s of the last century. Now it is reviving this procedure back. We first perform a coracoid osteotomy near the base to have a big chunk of the coracoid with the conjoint tendon. Then we prepare the bed, decortication, thus reaching a fresh bleeding raw area for better healing of our graft later on. Then we drill the two drills into this chunk of the coracoid. Then we place the graft and drill through the previously drilled holes via the scapular neck. Then we fix the graft using two screws. This acts by two mechanisms. First, it increases the glenoid surface, thus better contact between the head and the glenoid, and the slack effect of the short head of biceps. When the arm is placed in abduction and external rotation position, the short head bicipital tendon acts as a band in front of the humeral head to prevent any further anterior translation. We cannot leave shoulder instability without discussing posterior shoulder instability. It is common, yet it is commonly missed. The incidence is variable. In literature, varying from 4 up to 10 and even more % of all shoulder dislocations. The mechanism of injury is simple. Axial loading while the arm is in the adducted position, folding the outstretched hand. The head moves posteriorly. So axial posterior loading in the adducted arm. The other very common injury is electric shock, sudden muscle contraction. The infraspinatus is contracting while the subscapularis, pectoralis major, latissimus dorsi, and teres are also contracting due to the electric shock. The infraspinatus tends to internally rotate the head, externally rotate the head, while the subscapularis, pectoralis major are internally rotating the head, and the latissimus dorsi and teres are pulling the head backwards. So only the infraspinatus is acting against all other four muscles. The subscapularis, the pec major, the latissimus dorsi, and the teres are tending to internally rotate the head and push it posteriorly, while only the infraspinatus is fighting that. So the head would dislocate posteriorly and not anteriorly. Surgical procedures to treat recurrent posterior shoulder dislocation include posterior labral repair, what's known as the reverse Bankert repair. It's the same procedure as that used for anterior Bankert repair. Or capsular repair, which is a posterior inferior capsular shift described by Neer. Or bone block procedures, in which if there is loss of more than 25% of the glenoid, we perform a reverse or a posterior letter Usually it is very difficult to use the coracoid, so we use an iliac crest graft in such a case. This increases the glenoid surface, preventing the head from dislocating posteriorly. Another procedure that has been described by Neer is scapularis transfer, in which there is an osteotomy of the lesser tuberosity, and it is transferred to fill the defect in the humeral head. This is indicated in cases where there is loss of more than 25% of the humeral head. Another procedure has been described in the late 50s is scapular neck osteotomy. It's an opening wedge osteotomy performed for cases where there is excessive retroversion of the glenoid. Another procedure which was described by the Indians in the late 60s, it's now repopularizing. It's a humeral derotation osteotomy, in which the head is osteotomized at the level of the surgical neck, rotated anteriorly to prevent it from, or to reduce the retroversion of the head, which is normally 30 to 35 degrees. So I hope now you have got a good idea about shoulder instability in general. And if you need anything more, there will be more sessions such as this. Thank you very much.